Hello from Anaesthesia Journal. My name is Susannah Patey and I'm an Associate Editor of the journal. Today, Dr. Hansel and colleagues have published a new paper looking at clinical tests for confirming tracheal intubation or excluding esophageal intubation. This is a really important and very relevant topic because there's a lot of debate after the publication of the recent PUMA guideline regarding the utility of clinical tests for esophageal intubation. I think as anaesthetists, we can all say that we've all intubated an esophagus, but for the vast majority of us, we recognised it and we took the tube out promptly and no harm happened to the patient. However, sadly, unrecognised esophageal intubation is still happening and it has very, very serious consequences for patients. I think one argument when I bring this up with colleagues is that it's such a rare event, unrecognised esophageal intubation, and therefore, because it's a rare event, we don't have a lot of evidence for what we do. And I think this study really does show that we do have a decent evidence base to work with. And I'd like to introduce both Dr. Jan Hansel and Dr. Tim Cook, who are both authors, who are going to talk to us a little bit about the paper today. So first of all, Tim and Jan, why did you undertake the study and how did you do it?
So I'll take that. And hi, Susannah, thanks very much for asking both of us to take part in this podcast. But is it podcast? Is it Twitter? Whichever, video interview. So I think you've laid a lot of it out quite correctly. When we undertook so I became involved in the guidelines that were predominantly written by the PUMA group. In the wake of my knowledge of a series of cases of fatalities or serious harm from undetected or unrecognised esophageal intubation. And in the wake of Glenda Logsdale's death and the coroner's report, I felt that we needed to act. And to cut a long story short, I then joined for this project the PUMA group to write some guidelines, which have subsequently become essentially international consensus guidelines. And as part of that, one of the PUMA team, Adam Law, did an analysis of clinical examination to determine its value in excluding esophageal intubation, not detecting tracheal intubation, but excluding esophageal intubation. And that was included, effectively, the results of that were included sort of in passing, or the consequences of it were included in the review, in as much as we said that the value of clinical signs for excluding esophageal intubation were inadequately sensitive or specific, and therefore that they shouldn't be used to exclude esophageal intubation. Now, we knew this was going to be controversial. We knew it was going to cause a bit of furore, and it certainly has done, both in contact with us, discussion at meetings, and on social media. And so we thought that we should probably formalise that analysis that had been done by Adam Law. So we then brought in Jan for his specific systematic review expertise, having done excellent systematic review on video laryngoscopy and direct laryngoscopy. And so with Jan's expertise, essentially Adam and Jan did the legwork, the technical analysis, and then Nick Crimes, Andy Higgs, and myself supported that and put the work together. So that's where we are. So it's trying to give, as you say, a bit more robust science to the guideline, where we say a clinical examination not good enough.
Okay, so tell me a little bit about the methodology. You sort of started to hint at it a little bit there, and why did you pick sort of statistical methods that you did?
So just briefly on the basic methodology. So this is a diagnostic test accuracy, systematic review, and meta-analysis, and there are guidelines in place on how to conduct these and how to make comparisons. We did not undertake a network meta-analysis, which would compare each and every test to one another and give us sort of a ranking review. But we just chose to sort of assess each test in itself as compared to the gold standard, which mostly was waveform capnography. So this was sort of underpinning it. Then we had to choose which statistics to present. The first one that seemed most obvious was the false positive rate, which is a very simple and robust statistic that gives us an indication of how often a test will be falsely reassuring. And in the context of undetected esophageal intubation, this is probably the one that we're most interested in. The second one would be likelihood ratio, and maybe Tim can give us a bit more on this.
Yeah, so the positive predictive value and the negative predictive value are tests that are often used when people are talking about the value of tests, but they're not very useful for rare events. So because most of the time we put the tube in the right place, if you were to toss a coin and say whenever it came up heads, that was indicative that you were in the right place, then when you picked a head, you'd be right most of the time, because we're right 99 or more % of the time. So that as a predictive test would have a high positive predictive value, but it wouldn't be a useful test for whether the tube's in the right place. We know that capnography is a reliable test, and there are some other tests that are reliable, which we might talk about. But we particularly wanted to talk about the clinical tests. And the clinical tests, maybe Jan will come back to the clinical tests, but the positive predictive value, which, as I say, a lot of people rely on, and the negative predictive value, they are dependent on the frequency of the event that you're looking at. So we wanted to use tests which were less reliant on that. And therefore, as Jan says, the false negative rate, the frequency with which we are fooled into thinking that the tube's in the right place, is a useful one. And then the second statistical representation we used was what's called likelihood ratios. And the likelihood ratios are not dependent on the frequency of the event. So they indicate the relative odds of a test occurring in patients with and without the condition being tested for. This is what we've written in the paper. So a positive likelihood ratio describes the relative odds that a positive test is correct. So for the test we're looking at to confirm tracheal intubation, the positive likelihood ratio is the odds of the test that the test correctly indicates the tubes in the trachea relative to the odds that the test erroneously indicates the tubes in the trachea when in fact it's in the esophagus. So we want a test that has, for detecting tracheal intubation or for detecting effectively the converse is excluding esophageal intubation, we want a test with a very high positive likelihood ratio. And then there's also a negative ratio. So the negative likelihood ratio is the odds that a negative test is incorrect. So that is when the test indicates esophageal intubation, the odds that the test indicates esophageal intubation when the tube's in the trachea, relative to the odds that the test indicates the tube's in the esophagus when it is in the esophagus. And we want that to be very low. So we want tests to be discriminating by having a very high positive likelihood ratio, something well above 10, probably in the 20s and 30s, and a very low negative likelihood ratio, significantly below 0.1, so that they're incorrect only a tenth of the time.
Yeah, I think also when you look at the data analysis you've done and you look at how you framed it, the numbers are alarming. I mean, when you're talking about tube misting, I think it's something like an 80% false positive rate. Please correct me if that's not right, but those numbers to me clinically are very alarming. It's really nice to hear you explain them, because when you read it, it's quite sobering reading the things that we immediately look for when we've intubated a patient. Yeah, essentially saying are not accurate, they are not good measures.
Yeah, I mean, Jan might want to talk to the results a bit more than me, but one thing I would emphasize is I think this paper is worth reading because it's a statistical paper. We set out to present the statistics about the reliability of these tests, but it is framed very much as a clinical paper. So we have made considerable effort, and I'm very pleased that anaesthesia has given us the latitude to describe the test that we're doing. So often, if you write a paper which is based on statistical sort of analysis, then there's an assumption that everybody who's reading it understands those statistics. But anaesthesia has been very kind in giving us latitude to try and lay out what those statistics mean, which makes it hopefully approachable and clinically relevant for people who are not as statistically expert as Jan and Adam in doing the analysis.
Yeah, and I think that shows, because I think personally I think it's quite a reasonable read, and that you actually understand your thought processes underneath that, and this particular emphasis that, again, like as I said at the beginning, it's a rare event, and how do you get decent stats and decent evidence base on something that's a rare event? And I think you've addressed that really well in the paper, and that comes across well. So just talking about something sort of a bit sort of, and we talked a lot about stats, but we're going to go a little bit more clinically now. So you mentioned a lot about sort of esophageal detector devices. Now, this is not something that I commonly use in practice, and I think many of my colleagues don't. And this of all the other methods apart from capnography has a relatively low false positive rate. And it's also in the PUMA guidelines as well. So could you just talk to us clinically about what they are, what they do, and do you think we should be using them? Should they be on our difficult airway trolleys if they're not in every anaesthetic room?
So if I can take this one maybe to begin with, maybe just a quick description of what the esophageal detector device actually is for anybody who might not have used it. I've not used it myself in clinical practice. I'm not sure if any of us joined in this video call have, but that does not mean that it isn't used somewhere in the world. And by including it, we wanted to, sort of avoid selection bias that might come about from sort of assuming that our practice is reflective of practice anywhere else in the world where resources might not allow for waveform capnography at the moment. Now, this is a crucial point. Going back to the esophageal detector device, a very simple way of imagining it is almost like a turkey baster. So it has a bulb, and that bulb is collapsible, and you attach it to the tube once you've intubated either the trachea or the esophagus. So you can attach it with the bulb collapsed, or you can attach it as it is and then sort of press it down to collapse it, and that will insufflate air into either the esophagus or the trachea. If it happens to be in the esophagus, what happens is that the air will go in, and then the esophageal muscles will just collapse afterwards. So the bulb will not reinflate, if that makes sense. Whereas if you inflate into the trachea, obviously air will exhaled air will flow back, and that will reinflate the bulb. And the performance characteristics of this test are decent enough to have warranted inclusion into the PUMA guideline. So that's sort of where we are with the esophageal detector device. Whether it warrants inclusion in the sense of promoting its use, that's an entirely different question. We need to just be cognizant of the fact that these were mostly historic studies. So we're talking about studies that were mostly done in the 90s, before the advent of widespread waveform capnography. Waveform capnography was sort of coming into more widespread practice at that point. And by the early noughties, these studies have sort of tapered off. And this is probably to do with just more and more widespread adoption. All of that being said, a recent Twitter poll was done on, have you ever used an esophageal detector device? We have no ways of knowing who actually responded or how valid that is. But a proportion of respondents did say that yes, they have used it and or they have seen it in clinical practice. So this might indicate that there might be a degree of bias by not considering it at all. So we might have to keep it in consideration for the time being, whilst sort of scaling up universal, for lack of a better word, waveform capnography.
Yeah. I think that's interesting. I think actually the only time I have used one was a very, very long time ago, and in a cardiac arrest bag. There was one there. But now, generally, waveform capnography is much, much more available in hospitals, in remote sites in hospitals. Let's put it back.
I think it's important to emphasise that we're not promoting use of esophageal detector devices, and we're absolutely it's fundamental. The starting point is that capnography is better than all these tests, and that the diagnostic test you need to use to determine whether your tube is in the right place is capnography. Almost end of. But the fact of the matter is that the trainees that I work with, continue to say to me, I see misting, I see chest rise, now I'm going to look at the capnograph. And the danger is that if we use unreliable tests and they say, I see misting, so I think the tube's in the right place. I see the chest rise, I think the tube's in the right place. I see the capnograph, what's going on with the capnograph? There must be something wrong with the capnograph. It puts them in the wrong frame of mind. So we're presenting the data. And within that, the esophageal detector is a role. But we'll come now perhaps to the results, I imagine.
Yeah. So I think what's really important is the results, and as you said, and it's going back to again being capnography being the gold standard. So is that your main message from this, that whatever else you do, capnography is still the gold standard, and we almost shouldn't be biasing ourselves by using these very soft signs, because that's what essentially this paper is saying, is that we are verbalizing and talking about soft signs. They're not concrete, and this is biasing our opinion when we then look at the capnograph.
Exactly. I'd just like to echo Tim's view here. We're biasing ourselves in the sense of just cognitively priming ourselves for saying, yes, we see misting. Now, saying that misting, the absence of misting, can be helpful. So if you don't see misting, that can lead you to suspect that the tube is very likely to be in the esophagus, whereas the presence of misting is untelling entirely. So we just should avoid that sort of sequence or that spiel of chest rise, misting, capno, and it should probably go out of our collective vocabulary. Saying that as someone who has been trained to say this, I've since stopped. So can
I jump in? I just want to make sure that we do emphasise the results. So you obviously need to read the paper to get the results. But for misting, as Susannah said, we have a false positive rate of almost 70%. So it is so 70% of the time that the tube is in the esophagus, there will be misting.
Yeah.
So when you see misting, it tells you nothing, effectively. And then if we look at the likelihood ratios, the positive likelihood ratio, then the positive likelihood ratio is 1.5. So that means that if the test indicates the tube's in the trachea, it's only 1.5 times more likely to be in the trachea than the esophagus. And the negative ratio is low. So if you get no misting, it's highly likely that it is in the esophagus. So the negative ratio, the negative likelihood ratio is 0.02. So if you get, as Jan says, if you get no misting, you can go on 50. It's 50-fold more likely to be in the esophagus than it is in the trachea at this point. So it's quite useful for diagnosing. The absence of misting is quite useful for diagnosing esophageal intubation, but it's useless for ruling it out. And so this is what the guidelines say, and this is what the data says. And if you go through lung auscultation, whether it's just listening to the chest, or whether it's 5-point auscultation, which I guess is here, and stomach, then those are better, but they're still pretty unreliable. So for lung auscultation, 5-point auscultation, they've got positive likelihood ratios of about 7 to 9. But they've also got, so that means that if they're positive, you're likely to be okay, but it's not reliable. But they have got false positive rates of about 0.15. So that means 1 in 6 times it will be wrong. So we'll miss esophageal intubation 1 in 6 times of the times that esophageal intubation occurs. And it's also worth putting these results in context, because these are studies which are set up specifically to look at this. So they're set up, they'll be done by people who are experienced, by and large. They'll be done in ideal circumstances. They'll be done in a laboratory or quiet quiet clinical setting where people can hear, where people can see, where there's no pressure. In the clinical circumstances where the capnograph is flat and you're trying to work out what's going on, and the ODP has just pressed the alarm bell and 20 people have just arrived in your theatre or anaesthetic room, then your ability to listen to the lungs is going to be significantly compromised compared to these studies. So I think these probably suggest, and then there's that confirmation bias. I really want the tube to be in the right place. I listen to the lungs. I'm sure I can hear something. We've all seen that. So I think these represent the combination of the false positive rates and the likelihood ratios suggest that these tests are not discriminating enough. They're not reliable enough for us to rule out esophageal intubation, and we should be using capnography. And we should then be following the guidelines. If capnography says, don't think this is in the right place, we follow the guidelines. And that doesn't mean going back to listen to the chest.
Okay. Maybe just to add to what Tim said as well, situational complexity in the context of an unrecognized esophageal intubation just increases with time as well. And we have to consider that setting is quite important. So we're talking about the theater setting in a very controlled environment, and you could argue that an elective case in the theater setting is actually pretty much controlled compared to, for example, pre-hospital intubations, where the base rate of undetected esophageal intubation or esophageal intubation that fortunately does get detected is much, much, much higher because of the circumstances that those intubators work in, or you might have a different skill mix as well, which has been changing over the years too. Interestingly, the lung auscultation studies, a large number of them are actually done in the pre-hospital environment, so before the patients even come to hospital. So that's quite telling. And Tim will be able to say more about the anatomy of an unrecognized esophageal intubation, but there's this sort of almost like vicious cycle that takes place where it will ultimately lead to a cardiac arrest if not recognized, and then complexity just increases exponentially with more people coming into the mix as well, and it just clouds collective judgment. And at that point, we just need to go back to basics, use capnography.
Yeah. I think that's an important point that you've raised, because when we talk statistics and we talk about tests, a lot of this is done in a very calm environment. And essentially, when you've got an unrecognized esophageal intubation, you've got 2 or 3 minutes before serious harm is happening to your patient. And that's assuming that you had good oxygenation. That's assuming that you were able to oxygenate while you were waiting for your muscle relaxant to work. So the clock is ticking. So something with a high false positive rate is worrying in that situation, because you do not have the time to do anything else. You have to act. You don't have a lot of time. So relying on something that does have these high false positive rates, I think is no good. But so, however, whenever you present a body of evidence like this to a group of anaesthetists, because we've all got huge amounts of experience, we've all intubated a lot of people, someone will always say but. So I want to talk about the anaesthetic but. So there are always going to be special circumstances in which people are saying but you can't use capnography, you can't use it in this situation. So I mean, the common things are, again, there's high pressure scenarios, it's the cardiac arrest situations, low cardiac output. So things like bronchospasm, people, but you can't use it. Can we talk about those? And I think this paper does bring some clarity to those situations as well, as along with the PUMA guidelines.
So I think, if we're looking at the big picture, I think, so one of the questions is are we saying clinical examination is rubbish, it's of no value? Yeah. No, we're saying the clinical examination, we're saying exactly what it says in the PUMA guidelines, which is clinical examination is unreliable in ruling out esophageal intubation. And in terms of most unreliable, completely unreliable is misting. Just don't use it, forget about it. Chest auscultation is not bad, but it ain't really good. And all the tests, misting, chest auscultation, 5-point auscultation, are better at identifying esophageal intubation. So when you can't hear any sounds or you don't have any misting, they're a useful test perhaps for identifying esophageal intubation, but they're not sufficiently reliable because of that high false positive rate and a relatively low positive likelihood ratio. So they're not reliable enough. We need something that's bang on when we want to rule out esophageal intubation. So the guidelines say, if you've got a dodgy capnograph and you're uncertain, you just take the tube out. You don't go back to listen to the chest. You don't go back to seeing whether you got misting. You take the tube out and go to a place of safety, ventilate with a mask or supraglottic airway, and then work out where you are. So get to that place of safety. In terms of bronchospasm, I think the frequency of bronchospasm causing an absolutely flat capnograph is pretty rare. And I say that in the light of NAP7, amongst other things. I don't think it happens never. But if you've got no CO2 coming out when you're squeezing the bag, and you think it's bronchospasm, then you're not ventilating the alveoli. If you have no CO2 coming out, the alveoli are not being ventilated. So the tube might as well come out, because it may be esophageal intubation. And certainly, including in NAP7, there were more cases of undetected esophageal intubation, I'm afraid. And there's one of the elements of the guidelines which falls onto this is the element of humility in airway management, being prepared to be wrong, saying, look, I think I've intubated this patient, but the capnograph's dodgy. It could be absolute bronchospasm, but I don't want to miss an esophageal intubation, so I'm taking the tube out and work out where we are. If you still can't ventilate the patient, you probably haven't lost a great deal, but you may have saved the day simply by extubating the patient at that time. And it may even improve bronchospasm if it was due to bronchospasm.
Yeah. No, thank you. I think it's a very important point to clarify, because I think we've got ourselves in a situation where it's going back to what Jan said earlier. We put the tube in, the ODP or the anaesthetic assistant says, oh, that felt good. You then think, oh, I've got I've got misting, I've got chest rise, and then you look at your capnography trace. And that's kind of been the way that I've been taught. So to do this is this big shift in culture, really, and actually recognizing that what we have been doing for a while is prone to error, and most of the time, the vast majority of the time, we are fine. But this is not something, this is something that could happen to any of us.
So Susannah, perhaps my last comment, I'd like to say where I think we should move to, and it's slightly outside the limit of this paper, but it's within the PUMA guidelines. So I think we should move away from that. ODP says it feels okay. I can see misting, I can see chest rise. Now let's look at the capnograph. And we should be moving towards what is still a two-person check, but that is with video laryngoscopy, the anaesthetist saying, I've seen the tube go through the cords, the ODP independently confirming that, not saying I agree, but making their own assessment, which requires some teaching. And then both of them independently saying what they think about the capnograph. I can see sustained exhaled carbon dioxide. I can also see sustained exhaled carbon dioxide. We've been doing some work on that in Bath, and I think that is, and at Guy's, and I think that really is a place we need to get to, and I think that will be very helpful.
In terms of the paper, it's available today via the anaesthesia website. It is free access for all. This is important information, and we hope that everyone watching this goes on to read the paper in full. Thank you very much, Tim.